right, guys, let's see how this goes. So I kind of want to start this series to help myself learn, deep dive a little bit further into some of these diagnoses and treatment plans and all that good stuff. So while I hope you learn something along the way, a lot of this is just for me to help me research and get a good grasp on what I'm learning. So that being said, I'm a student. I'm not yet a professional in this specific space, in the psychiatric space. So don't take this as medical advice. We're just learning together. All right, let's talk about depression. As I go through this PMH&P journey, I realize that there's so much more to each of these diagnoses than I originally thought. But I am going to try and break down the most important parts that we should know about while still trying to throw some graduate level info in there. So let's see what we can get into. All right, what is depression? I'm sure we've all heard the term before, and probably for years now. I know sometimes we like to throw around these terms without thinking about the clinical side of it, like, what's wrong with you? You're kind of quiet today. And someone's saying, oh, I'm just depressed, probably need a little sleep, feeling a little off. But what is depression as we know it in the professional world or in the clinical world? It's classified as a mood disorder, and this is because the diagnosis is based on a disturbance in our mood, our outward expression of emotion, or our inner emotional feelings. Depression actually has quite a few subcategories, but what they all have in common is some kind of mood dysregulation, a persistent sadness, or a loss of interest in things we typically enjoy. Maybe also functional impairment. Maybe we can't get out of bed long enough to take a shower or to do the things that we need to get done in a day. Our subclassifications include Major Depressive Disorder, and this is the one we'll really be diving into today. If I tried really digging into all of them, I'd probably end up a little confused. The video would be hours long trying to separate the criteria. So we're going to stick to Major Depressive Disorder with this. But we've also got Disruptive Mood Dysregulation Disorder. It sounds like this one's relatively new when it comes to the DSM-5. It was added in 2013, and it is a diagnosis specifically used for kids and adolescents. Features of that diagnosis include irritability in children and frequent tantrums and outbursts. There's obviously a lot more to it than that, but we're not digging into that one. Then we have persistent depressive disorder, otherwise known as, or previously known as, dysthymia. So this is a chronic form of depression that lasts for at least 2 years. Symptoms are often less severe than major depressive disorder, but longer lasting. So just feeling down most days of the week for at least 2 years. Then we have premenstrual dysphoric disorder, which is a severe form of PMS or premenstrual symptoms. I always just call it PMS. It doesn't roll off the tongue very easy. It has similar symptoms to major depressive disorder, but it's obviously cyclically linked with hormonal fluctuations, aka it happens very obviously around your period. That's the big difference. And finally, we have a large category called depressive disorder due to other medical conditions. So that'll be further broken down into even more specific subtypes like substance-induced depressive disorder, medication-induced depressive disorder, and depressive disorder due to medical conditions like hypothyroidism. So we already see there's a lot more to depression than a sad mood. There are many categories, there are many causes, and there's a lot of different treatment options. All right, so let's take a look at the criteria for the diagnosis of major depressive disorder. So this is straight out of the DSM-5 text revision. So in order to be diagnosed with major depressive disorder, a patient must meet 5 out of the 9 listed symptoms, and at least one of those symptoms must be depressed mood or anhedonia. So let's go through them one by one. Depressed mood, pretty straightforward, feeling low, feeling sad. This is the emotional aspect of the mood disorder. Next, we have sleep changes. And this is what we call a neurovegetative symptom. Neurovegetative symptoms are symptoms that reflect body changes or physiologic changes. So when we consider sleep in the context of depression, someone may be sleeping too much, having trouble getting out of bed, or maybe sleeping too little. They might be overwhelmed with feelings of inadequacy or suicidal thoughts and unable to get to sleep. There are also specific instances where maybe they get to sleep okay, but they wake up really early in the morning and they're unable to fall back asleep. They call it early morning awakenings. Pretty straightforward. So any changes to sleep patterns are important to consider. Then we have anhedonia, or loss of interest in things or activities. This is one of the big ones that can make the diagnosis of major depressive disorder. Diminished pleasure in things you used to enjoy. Maybe you don't feel like hanging out with friends anymore, or you used to enjoy music and now you have no interest in it. Next, we have guilt or feelings of worthlessness. Sorry, my dog really wants to play fetch right now. So this is negative self-talk or negative thoughts, like I'm the reason my relationship failed, or maybe it manifests as imposter syndrome. I don't know why I still work here. Doesn't anyone realize I don't know what I'm doing? Eventually they'll find out I'm a fraud. It's a vicious cycle of negative self-image. Then we have energy loss or fatigue. This is another neurovegetative symptom because it physically affects the body. We have concentration problems, which is just what it sounds like. No effort or motivation to concentrate or focus. Some people describe it like they're in a fog or moving in slow motion. Appetite changes are another neurovegetative symptom. Some people might find that they're eating too much to fill a void or ease emotional discomfort, while others are so tired and disinterested that they may forget to eat altogether and possibly have weight loss associated with it. Then we have psychomotor agitation or retardation. Agitation refers to a restlessness, fidgeting, anxiety, hand wringing, movements that are likely noticeable by the people around them. And then on the other hand, there may be a psychomotor retardation, and that's the opposite. It is a slowing of movements, maybe slower speech, again to the point where it's noticeable by other people. Their friends may bring it up, or if it's a patient you're interviewing, you may be able to see it as you speak with them. These are also considered neurovegetative symptoms. And then finally, we have suicidal thoughts. The best way to evaluate this is to ask outright. So have you ever thought about killing yourself, or that you'd be better off dead? Do you have a plan in place? Have you ever started getting things ready for a plan, such as writing out a will or giving away your items? Asking does not plant the idea, and it may save your patient. All right, let's talk a little bit about differential diagnoses. This is important because we really have to narrow in on the diagnosis. If it could be anything else, there may be other treatment options available. So in order to make our best treatment plan for our patients, we need to make sure we have the right diagnosis. First, we have biological causes. We may hear a lot about hypothyroidism. Some symptoms of hypothyroidism may mimic what we see in depression. We could see fatigue, psychomotor slowing, maybe some cognitive difficulties like brain fog, sleep disturbances, and appetite or weight changes. So a lot of overlapping symptoms. And this is why it's important to have baseline lab work done on our patients. It's ideal if a patient has been following with a PCP, but let's face it, that's not always the case. So ordering a TSH and T4 are crucial to ruling out biological causes. Another biological cause may be vitamin D deficiency. Vitamin D affects neurotransmitter synthesis like serotonin and dopamine, and we really see the effects of low vitamin D in the winter in areas that don't get much sunshine. We have the diagnosis of seasonal affective disorder, or SAD, to describe these symptoms that happen specifically as the seasons change and we see less sunshine and get less vitamin D. So this is another important lab test to rule out biological causes of depressive symptoms. I live in Northeast Ohio. I see many patients at my psych job and in my ICU job on vitamin D supplementation because it can be vital to a healthy brain. So those are just a few examples of biological causes of depressive symptoms. Now let's go ahead and take a look at substance or medication-induced depressive symptoms. So this can be related to the drug or substance itself, or as a result of stopping the drug, such as and withdrawal symptoms. So alcohol is one substance where heavy or chronic use can cause low mood, fatigue, or sleep disturbances. Beta blockers, those can cause fatigue, sometimes sleep disturbances, corticosteroids. So it's important to get a good history on the patient and have an understanding of the medications they're on or the recreational substances they may use. Then we have anxiety disorders, and we may see some overlap with difficulty concentrating or maybe a low threshold for frustration or irritability. And let's keep going clockwise around this circle and hit up adjustment disorder with depressed mood. This refers to a depressed mood that's in response to a psychosocial stressor. That's the big difference, a clearly identifiable stressor. According to the DSM, symptoms typically come on within 3 months of the stressor, but usually only last around 6 months before fizzling out. All right, now we have other depressive disorders. That's what we talked about on the other slide that included dysthymia, or the persistent depressive disorder, the premenstrual dysphoric disorder. And the differences here usually involve length of the depressive episode, severity of the depressive episode, and whether or not it follows a pattern, like in premenstrual dysphoric disorder. And then finally, we have bipolar disorders. So bipolar disorders are known for their ups and their downs, episodes of depression separated by typically short periods of mania. So when ruling out bipolar disorder, especially bipolar 1, it's important to ask if they've had those manic episodes or periods of time where they have felt on top of the world, or like they don't need any sleep. They can spend hours fixated on a project or filling up a journal. There are a lot of psych diagnoses with overlapping symptoms, which is why it's so important to develop a good relationship with your patient and spend time getting a good history and medical understanding of them. Okay, this may be a long one. There's so much that goes into the causes and risk factors and overall pathophysiology of depression. So let's first look at the genetic component. According to the DSM, that is where most of this information is coming from, heritability is about 40% for depression, which means about 40% of the risk associated with developing major depressive disorder comes from genetic factors. And the other 60% are a result of environmental factors, stressors, or lifestyle. Women are also 2 times more likely to develop depressive symptoms than men. All right, then we have neurotransmitter dysregulation. So this is where we get the monoamine hypothesis. Monoamines are a group of neurotransmitters that share a similar structure, and they're associated with regulating mood, arousal, attention, motivation, and rewards. The main monoamines we think about are serotonin, dopamine, norepinephrine, and sometimes histamine. The monoamine hypothesis, as it relates to depression, says that dysregulation or too little of one or more of the neurotransmitters leads to the depressive symptoms. And that's where we get one of our big classes of antidepressants from, the monoamine oxidase inhibitors. This class tends to carry more side effects than some of the newer antidepressants, like orthostatic hypotension, weight gain, sexual dysfunction, and some drug-to-drug interactions. So then I have brain structure listed separately, but it's actually a combination of all of these other causes and risk factors. So there may be a genetic cause as to the development and structure of the brain. That's how that kind of plays into the structure component. Then we have the neurotransmitter dysregulation that plays a part as well. The big picture there is that the dysfunction of the neurotransmitters are some of the first steps in a cascade that leads to synaptic pruning, so fewer synapses, reduced hippocampal neurogenesis, prefrontal cortex thinning, and amygdala hyperactivity. So a literal changing of the brain structure related to changes in the chemistry. And finally, we have HPA, or hypothalamic pituitary adrenal axis dysregulation. This system is typically responsible for stress and cortisol management. During times of excessive stress, this system never turns off, and we see an excess of cortisol. Chronic high levels of cortisol lead to reduced neurogenesis and dendritic loss in the hippocampus. It also leads to hyperactivity in the amygdala and prefrontal cortex suppression. So now we see how outside stress causes actual changes to our hormones, which in turn changes the structure of our brain and the clinical symptoms that we see in our patients. And these symptoms look like poor concentration, memory problems, maybe heightened anxiety, rumination, and impaired emotional regulation, among other things. Now let's see what the assessment and screening might look like. One of the most important things we can do is an in-depth clinical assessment. We need to take a good history and get an idea of what kind of symptoms our patient is having and how long they've been having them. And although this is arguably the most important step, it's not always the first step. So if you've ever seen a PMHNP or a psychiatrist, or maybe even just a new primary care provider, you know that there's typically intake paperwork you have to do. Sometimes this is on a portal on the computer. Sometimes it's in person. They'll hand you a packet of paperwork to go through. And then this intake paperwork gives the provider a glimpse of your history, saves a little bit of time during the appointment itself. With this glimpse we get from the intake paperwork, we may start thinking about other assessment tools or questions that we want to ask during the appointment. The PHQ-9 is a common screening tool that I've seen as part of pre-appointment paperwork in psych settings and in primary care offices. PHQ-9 stands for Patient Health Questionnaire 9 Questions. So it's a 9-question assessment of sorts that will give us a number associated with depression severity, from no depressive symptoms to severe depressive symptoms. And of course, this is not the end-all be-all of depression diagnosis. It's just a tool meant to start a conversation between the patient and provider and figure out the next steps. We also have the HAM-D, which stands for the Hamilton Depression Rating Scale. And honestly, I've never seen this one used in practice because it takes more time than the PHQ-9, and it has to be administered by a clinician versus the PHQ-9, which is essentially self-reported. It sounds like the HAM-D screening tool is most often used in research when doing clinical trials with antidepressants as a tool for measuring severity of depressive symptoms. And then we've got the Beck Depression Inventory, or the BDI. This is a self-reported questionnaire designed to measure severity of depression symptoms. So again, not diagnostic, just symptom severity. It's got 21 multiple choice questions, and scores represent minimal to severe depression. And then in addition to these screening tools, it's important to have some baseline lab work to look at. We kind of talked about this earlier. It's important for ruling out differential diagnoses with a medical cause like hypothyroidism or anemia. And then of course, vitamin D levels are important to check, especially in Northeast Ohio, when there's a good portion of the year where we don't see a lot of sunshine, and that can definitely impact our mood. So when we incorporate all of these assessments and screening tools, you can see how we start to get a better picture of our patients and what might be going on with their mental health or their physical health. Now let's talk about treatment. So it has been shown that the best treatment plan for depression involves combination therapy. But let's go ahead and go through them one by one. First, we have psychotherapy or talk therapy. This may be considered first-line treatment for a mild depression, but once you get past that at all into moderate or severe categories, it's time to combine it with pharmacotherapy. So cognitive behavioral therapy, or CBT, is the gold standard psychotherapy for depression because it focuses on identifying and changing negative thought patterns. So sometimes these thought patterns just occur without us being consciously aware of them. So when you talk with a professional, they may pick up on phrases that you keep repeating or maladaptive behaviors like self-isolation. They can then help you work through those. And as we've learned previously, it is possible to restructure our brains. We have functional MRIs that show increased prefrontal cortex activity and decreased amygdala response after CBT sessions. Now let's move down to the bottom one and look at lifestyle modifications. So included in lifestyle modifications, we of course have exercise, sleep hygiene, nutrition, stress management, mindfulness, and social support, among other things. So exercise helps to reverse the stress effects that cortisol has on your brain. In turn, that improves neuroplasticity. Sleep hygiene helps to reduce fatigue, reduce irritability, and cognitive impairment. And some examples of good sleep hygiene include a regular sleep schedule and avoiding blue light a few hours before bed. Stress management, of course, helps reduce cortisol and the effects it has in the brain. And then having a good social support system can activate your reward system and increase dopamine in your brain, helping to decrease isolation-related depressive symptoms. So there are a lot of things we can do from a lifestyle modification standpoint if our patients have the drive and energy to add them into their day. And sometimes that's a big if. All right, pharmacotherapy. This is a big category. I'm gonna try and condense it. This is general major depressive disorder, not necessarily specific pharmacotherapy. But there are many types of antidepressants. One of the first line antidepressants these days are SSRIs, or selective serotonin reuptake inhibitors. So in a normal functioning synapse between nerve cells, the neurotransmitter gets released from the axon terminal or the synaptic terminal. It hangs out in the synaptic cleft as they make their way to receptors on the postsynaptic neuron. Once these receptors are full, there's no need for the rest of the serotonin to hang out in the synaptic cleft, so it gets taken back up into the original nerve cell in a process called reuptake. The idea behind SSRIs is to allow the serotonin that's hanging out in the synaptic cleft to stay there longer by blocking the reuptake. And the thought is that this gives our receptors a better chance of binding, or this gives the serotonin a better chance of binding with our receptors, so you actually get the full effects of the serotonin. Essentially, the serotonin hangs out longer, so there's a better chance of it actually binding with the receptor. I don't know if I said that right the first time. And then we have another medication class that is very similar to that. It is for norepinephrine. So they're called SNRIs, or selective norepinephrine reuptake inhibitors. And both SSRIs and SNRIs are generally well tolerated. For the most part, pretty few side effects, mild side effects, makes them a good first line to try for our patients to see how they tolerate them. Then we have a class called tricyclic antidepressants. These antidepressants are named for their chemical structure. They have 3 fused rings of atoms, hence the tricyclic. These medications also block the reuptake of serotonin and norepinephrine, but they also act on histamine receptors, muscarinic receptors, and alpha adrenergic receptors. And because of the action of these medications, they may be useful for treatment-resistant depression, but they have a much worse side effect profile, and they are cardiotoxic in overdose. So when I was a new nurse in the ICU, I saw a patient come in with an intentional TCA overdose, and it was pretty intense. I was still in orientation, and my preceptor just had me stand back and watch as the room was prepped for the arrival of the patient. We had the defibrillator in the room, sodium bicarb fluids, the ventilator. It took a lot of resources to stabilize the patient. And there's so much more to cover when it comes to pharmacotherapy for major depressive disorder, but this video would be hours long and nobody has time for that. And I'm already losing my voice. So let's look at neuromodulation. This is an interesting one. I have never seen neuromodulation in practice, but it sounds like the clinic I'm going to for my outpatient clinical rotation this fall specializes in neuromodulation. So I'll get to see it up close and personal and report back with some pearls. Neuromodulation is reserved for treatment-resistant depression and includes therapies like electroconvulsive therapy, repetitive transcranial magnetic stimulation, vagal nerve stimulation, and deep brain stimulation. Ketamine can also be considered in the neuromodulation category as a chemical neuromodulator. The clinic I'm going to does ketamine therapy too, and it sounds fascinating. So that will have to be a separate video. And I think that's enough for this video. It's way too freaking long. Let's go over some takeaways. Just big picture items here. Depression is extremely common. It affects 7 to 10% of adults annually worldwide. It's treatable. As we just saw, there are many levels and treatment options for patients who struggle with depression. Early recognition improves outcomes, and we know this because of the impact depression has on brain structure. The earlier we recognize depressive symptoms, we can start planning the best treatment option for our patients. Depression is not just sadness. It's a brain-body disorder that changes your circuits, your energy, your thinking. It's very well studied, and there are options out there for everyone who needs them. So I hope you like this video. I will try to do more like this in the future. It is a little time-consuming, not only to research and make sure I have hopefully the most appropriate information, but also recording. We're 35 minutes into this. Hopefully I can cut it down a little bit. So we'll see how that goes. But let me know what you want me to deep dive into. And remember, like I said earlier, I'm a student. This is not medical advice, just a learning opportunity for me and hopefully for you as well. So have a great day and take care of yourselves. Bye.